When there is a subaortic gradient, we are going to see M mode, the so-called SAM, systolic anterior motion of the mitral valve, SAM. As we see here, mitral valve structures move toward the IVS during systolic, occupying the left ventricular outflow tract. It is said to be the leaflet itself, but I have doubt in some cases. Maybe this movement may be produced only by the chords. When the SAM touches the IVS, there always will be LVOT gradient. Even before Doppler, we could call this image as a hypertrophic cardiomyopathy with left ventricular outflow gradient. Here we see the classical SAM of the mitral valve by the 2D echo. Apparently, what seems to be chords, not the anterior leaflet, bend toward the left ventricular outflow tract during systole due to Venturi effect. In other words, the SAM may be due to the existing gradient pulling the chords and not a cause for the obstruction, as if it were the case if the SAM were due to the anterior leaflet moving to and obstructing the left ventricular outflow tract. Our impression is that SAM is produced by the chords that are elongated in relation to a small hypertrophied cavity. The subaortic obstructive jet pulls the chords to the left ventricular outflow tract by Venturi effect. Others say that the abnormal position of the anterolateral papillary muscle also predisposed to the SAM, mainly because the abnormal position of the papillary muscle and the left ventricular hypertrophy produces more tension at the base of the leaflets than at the central region. These central chords are then kind of loosened and free to project to left ventricular outflow tract. Some papers argue that the SAM is not consequence of the obstruction, but the cause, since the chords could not produce obstruction. They think that the anterior leaflet, and for some, the posterior leaflet, is what is dislodged anteriorly to the IVS, and hence producing gradient of the LVOT. They claim that when the mitral valve closes, it does not do it by the contact of the free borders of the leaflet, but at a region more inside the leaflet, away from the border. This would turn the borders free to bend toward the left ventricular outflow tract and cause obstruction. Once again, when we perform in the echo exam of patients with hypertrophic cardiomyopathy, the real impression that we have is that the free borders of the anterior leaflet connects with the free border of the posterior leaflet, and what seems to produce the SAM are the chords. I can't believe that we have a leaflet that comes this far down the left ventricle. Another finding in hypertrophic cardiomyopathy is this endocardial thickening right here at the LVOT. It may be the result of jet lesion due to obstruction of the left ventricular outflow tract, or due to constant striking of the leaflet of the mitral valve. These are the two possibilities for this very frequent endocardial thickening. Look at the thickening of the LVOT endocardium. But this case is much more interesting since it has an endocardial thickening, and although there were some aortic gradient, there were not an angulation of the mitral valve and no contact of the leaflet with the IVS. We see that the hypertrophied IVS enters and obstructs the left ventricular outflow tract and meets the chord. I believe this aspect indicates that the endocardial thickening is due to jet lesion and not due to contact attrition with the mitral leaflet. It also shows that the obstructive of the left ventricular outflow tract is due to the entrance of the IVS into the LVOT, and not due to the bending of the mitral leaflet, and that the SAM is consequence and not the cause of obstruction. We can divide the patient with hypertrophic cardiomyopathy in 3 different groups since the presence of and intensity of the SAM. Some patients present a SAM which does not touch the IVS. These cases are associated with patients with rest gradients, but presents gradients when LV cavity is diminished, like with exertion, some medications, or with Valsalva, for instance. And then the SAM reached the IVS. Others will have a SAM that reached the IVS, and there always will be subaortic gradient, even when the SAM is due to obvious submitral structures and not the apparent leaflet. As in this case, there will be gradient that may be midventricular, and other will not have any SAM and will not present a gradient, not even with provocative maneuvers or medications. These are the cases of hypertrophic cardiomyopathy with no subaortic gradient. The gradient also correlates with how early, for how long it touched the IVS. If it appears early during early systole and persists for a long time touching the septum, the gradient is higher than the contrary. And there is here another sign of this cardiomyopathy with obstruction. Observe that the aortic valve has M-mode closure with a late reopening of one or both cusps. The mid-closure corresponds to the clinical impression of this graphic as depicted in the carotid pulse.